Mood disorders. 1. Depressive disorders, major depression, single episode, recurrent dysthymic disorder, depressive disorder not otherwise specified. 2. Bipolar disorders, bipolar I disorder, bipolar II disorder, cyclothymic disorder, bipolar disorders not otherwise specified. 3. Mood disorders due to general medical condition and substance use. 4. Mood disorder not otherwise specified. Frequency of major depression, its lifetime prevalence is 3.5–5.8%. The 1-year prevalence is 2.6–6.2%. The prevalence shows a gender difference. It is 3–12% in men and 10–20% in women. The average age of onset is 27. 12–20% of cases tend to become chronic. 9% of those who have had a depressive episode also give a history of mania. The lifetime prevalence of any affective disorder is 7–8%. Consequences of depression: increased mortality, increased likelihood of fatal accidents, deaths due to secondary diseases, suicides, job loss, loss of productivity, deterioration in work and school performance, substance abuse, deterioration of family relationships, deterioration of physical health. Symptoms: depressed mood, lack of interest and pleasure, hopelessness, pessimism, anxiety, agitation, sadness, irritability, indecision, low or loss of self-esteem, thoughts of worthlessness and guilt, feelings of helplessness, inability to do daily activities, work, family, money and excessive preoccupation with health problems, lack of energy, fatigue, psychomotor slowdown, boredom, reluctance, suicidal thoughts, suicide attempts, decreased ability to concentrate, forgetfulness, alcohol and other substance use. Increase in the symptoms of existing physical illness, increase in the probability of contracting physical illness and mortality. Neurovegetative symptoms: low energy, fatigue, psychomotor agitation, slowing down, insomnia, hypersomnia, low libido, appetite disorder, weight changes, diurnal change in mood, constipation, headache. Risk factors for relapse in unipolar patients: number of previous attacks, chronic course, severity of current attack, accompanying psychiatric and medical conditions, current attack not responding adequately to treatment, residual symptoms, early onset, presence of personality problems, neuroticism, short REM latency, decreased TSH response to TRH, relative scarcity of delta sleep in the first non-REM period. Possibility of suicide: those with other mental illnesses, men, those with alcohol and other substance use problems, those who have experienced significant losses, loss of a loved one, job loss, divorce cases where social support is insufficient, those who experience important life events such as retirement, those who are single, those who are divorced, changes in life cycles, those who have attempted suicide before, those who threaten suicide, those who plan to commit organized suicide, those with concurrent medical illness, those with severe cognitive impairment, those with psychotic features, those with pre-existing brain damage, the elderly, those who plan organized suicide. The probability is higher in those with a current medical illness, severe cognitive impairment, psychotic features, pre-existing brain damage, and the elderly. What symptoms are considered signs of suicide? Frequent expression of feelings such as helplessness and hopelessness, behavior that differs significantly from one's previous behavior, such as the impulsiveness of a careful person, symptoms of severe depression. Those who show unexpected relief, this is considered a sign of determination to commit suicide. The risk is higher for those who talk about alienation, inheritance, life insurance, writing a will, death and dying. Which cases cannot be treated in primary care? Which cases should be referred to a psychiatrist? If there is a risk of suicide, food refusal, serious physical problems, resistant cases, cases with a tendency to become chronic, if additional treatment methods are needed, if there are severe negativism symptoms, if there is a possibility of homicide, if psychotherapy is deemed necessary, environmental support systems are sufficient. If not, it should be sent to a psychiatrist. Which patients need to be hospitalized? Those with serious suicide attempts, those with serious suicidal thoughts, those who make suicide plans, those who have a tendency to harm themselves and the environment, those who refuse food, those who have difficulties in maintaining outpatient treatment. Depression symptoms: emotional, low self-esteem, inadequacy and insecurity, sadness, anxiety, irritability, apathy, anhedonia. Psychological: guilt, hopelessness, helplessness, worthlessness, loss of pleasure. Cognitive: obsessive thinking, rumination, memory impairment, concentration impairment, suicidal thoughts. Social withdrawal, loneliness, social occupational dysfunction, marital and work sorties, financial problems. Neurovegetative: lack of energy, fatigue, psychomotor agitation, slowing, insomnia, hypersomnia, low libido, appetite disorder, weight changes, diurnal change in mood, constipation, headache. Psychotic symptoms: delusions, hallucinations. Laboratory tests: initially recommended laboratory tests: complete blood count, electrolytes, glucose, BUN, creatinine, LFT, calcium, phosphate, VDRL, urinalysis, serum and urine toxic screening, thyroid function tests, ECG, chorionic gonadotropin. Special laboratory tests: serum B12 and folate, sedimentation, anti-nuclear antibody, ceruloplasmin, PPD, LP, radiological examinations, chest X-ray, CT, MRI, single photon emission tomography, PET, other diagnostic tests, DST, TRH stimulation test, EEG, polysomnography. Psychiatric differential diagnosis: major depression, bipolar disorder, depressive episode, dysthymia, cyclothymia, personality disorder, borderline personality, normal grief, unresolved grief, reactions to loss, adjustment disorder with depressed mood, schizophrenia, post-psychotic depression, negative symptoms, anxiety disorders, depression due to somatoform disorder, eating disorders, substance use disorders, delusional disorders, dementia, other organic brain syndromes, obsessive-compulsive disorder, schizoaffective disorder. Causes: monoamine theory, norepinephrine, serotonin, dopamine, adrenergic cholinergic balance hypothesis, receptor sensitivity changes, NMDA system, GABA system, disorders related to secondary information carriers, biological rhythm disorders, neuroendocrine causes, immunological causes, cerebrovascular events, sensitization kindling view, genetics, dynamic causes, Beck model, learned helplessness model, personality structure. Course and outcome: 85–95% of cases use known methods. In untreated cases, the natural course is 6 to 24 months. It recurs in 50–70% of cases. The probability of recurrence is 50% after the first attack, 70% after the second attack, and 90% after the third attack. Early starters are more likely to relapse.